It's Val, one last time before second year exams. My exam's tomorrow, and I've finally gotten to the end of my study. And one of the final things I wanted to go through was my anterior pituitary hormone diagram, which I think has been really essential to my learning and my understanding of anything endocrinology at the moment. So I think I'm going to take you through this because there's a lot and it all makes sense in the end. So I'm going to start by going through like each of the kind of anterior pituitary hormones and what they do and how pathologies in of each of these kind of manifest. And then I'll go through our case, which had a prolactinoma. And it kind of shows exactly the symptoms that he presented with can be explained by deficiencies in each of these hormones. And it's really, really cool. And I will explain that in a bit. Okay, so starting off with the anatomy of the pituitary, we've got the anterior lobe and a posterior lobe. And the anterior lobe is called the adenohypophysis, and it is different to the posterior lobe in that there are hormones that are produced by the hypothalamus, and they travel through a hypophyseal portal system to act on the cells of the adenohypophysis, which then in turn produce all of our hormones. In contrast, the posterior pituitary secretes hormones directly into the circulation. And these hormones, which I'm not going to go through, are ADH or vasopressin and oxytocin. So basically, there are 5 different types of cells in the anterior pituitary. You have somatotrophs, which are stimulated by somatochordin, and they produce growth hormone. You get thyrotrophs, which are stimulated by thyrotropic releasing hormone, and this produces thyroid stimulating hormone. You get corticotropin releasing hormone, which stimulates corticotrophs to produce adenocorticotropic hormone. You get prolactin releasing peptide, which acts on lactotrophs to release prolactin. And finally, you get gonadotropic releasing hormone from the hypothalamus, which stimulates gonadotrophs to produce luteinizing and follicle stimulating hormone. Okay, so that's a lot, but I'm going to start with the most common type of pituitary tumor, which is lactotroph or prolactin secreting adenoma. So these make up 35% of pituitary tumors. And what prolactin usually does is it stimulates milk production in the lactiferous ducts of the breast. However, in a prolactinoma, which is defined by over 200 nanograms per mil of prolactin in the blood, you get an increase in prolactin, and what this actually does is it feeds back and inhibits the secretion of LH and FSH, which has a bunch of reproductive hormone consequences, and the physical size. So imagine we have a little tumor, it's pressing on all of these other cells, and so you're going to get decreased production of growth hormone, thyroid stimulating hormone, and ACTH as well. So starting with or moving on to the effect of gonadotrophs, we'll come back to prolactinomas in a bit. Gonadotrophs produce LH and FSH, and these act on our gonads. So in a male, these are our testes, and in the female, our ovaries. So LH and FSH have different roles in the male and the female. In the male, luteinizing hormone acts on Leydig cells, which produce testosterone. And testosterone is responsible for a bunch of your secondary sex characteristics as well as for aiding spermatogenesis. FSH acts on Sertoli cells, and these, amongst other things, they produce androgen-binding protein, which increases the concentration of testosterone in your seminiferous tubules, which helps all our little spermy boys mature. In your ovaries, FSH, stimulates our follicles, our ovarian follicles, and this leads to follicle maturation and increased estrogen secretion. Luteinizing hormone stimulates ovulation, so that's why you see like a big peak in luteinizing hormone during ovulation. And this leads to the production of the corpus luteum, and the corpus luteum is what produces progesterone. So as you can see, LH and FSH are indirectly responsible for the production of our sex hormones, namely testosterone, estrogen, and progesterone. So in the case of reduced FSH and reduced LH, for example, in prolactinoma, where prolactin is reducing the secretion of these via negative feedback mechanism, you'll get a bunch of different manifestations. So starting with males, in a young male, you'll get decrease in body hair and growth failure. And in an older male, you might see reduced libido, sexual impotence, hypogonadism, and fine wrinkles. In a female, you would get, in a young person, pubertal delay, menstrual abnormalities, and galactorrhea, which is milk production from the breasts in absence of being pregnant or having children. And in an older female, you might see amenorrhea, which is a lack of a period and a lack of menstruation, and again, galactorrhea in absence of having a child. Now, moving on to the other most common adenoma, pituitary adenoma, we have the growth hormone secreting pituitary adenoma. So if you get an increase in growth hormone or a GH secreting tumor, you're going to get something called acromegaly in adults or gigantism in children. And this is because the growth hormone acts on the liver, which in turn produces something called insulin-like growth factor. And what this does is it stimulates skeletal muscles and bone growth, so you get the enlargement of your hands and feet in adults. And in children, where their growth plates or physes haven't fused yet, you get gigantism, which is where you have an overall increase in body mass. And then if you get a decrease in growth hormone for any reason, for example, due to a pituitary adenoma of a different cell, you'll get growth retardation. And to test this, we look for insulin-like growth factor levels, because for some reason or another, growth hormone levels themselves are unhelpful in a blood test. Now, I'm going to go now to thyroid stimulating hormone, which is again secreted by thyrotrophs. And this is important because it's implicated in thyroid disease. So basically what happens is that thyroid stimulating hormone promotes this process in the thyroid. So in the thyroid, we have a protein called thyroglobulin and an enzyme called thyroid peroxidase, or TPO. And in the presence of stimulation from TSH, TPO couples and iodinates tyrosine residues on thyroglobulin, leading to the formation of two proteins, namely thyroxine and triiodothyronine, or T4 and T3. So this only can happen in the presence of iodine, and this becomes relevant because in iodine malnutrition or an iodine deficiency, you'll get reduced production of T4 and T3. And these are important because they're responsible for growth, metabolism, and development. So moving on to the manifestations of an increase or decrease in TSH, we get, firstly, hypothyroidism, which is caused by an increase in the production of these thyroid hormones, whether it's from an increase in TSH or whether it's from an increase in T4 and T3 in general. There are several causes of hypothyroidism, namely Graves' disease, solitary toxic adenoma, where you just get kind of one bunch of cells inside the thyroid producing too much T3 and T4. Multinodular goiter, which is where you get lots of little nodules producing excess thyroid hormone. You can get drug-induced thyroiditis. You can also get hyperthyroidism simply from exogenous thyroid hormone. So if you're taking exogenous thyroxine. And you can also get it from subacute granulomatous thyroiditis, which is characterized by fever, neck pain, and hyperthyroidism. Also known as de Quervain's thyroiditis. So because in hyperthyroidism, we get an increase in T3 and T4, and as we said, T3 and T4 are responsible for your growth, metabolism, and development. An excess of these are going to cause the clinical features of hyperthyroidism. Namely, I use the acronym sweating. So you get sweating, weight loss despite an increase in appetite. That's important. Get emotional liability. So for example, someone might be more anxious. You can get tremor and tachycardia, an intolerance to heat because of your increased basal metabolic rate, meaning that your body temperature is generally raised. And so if you're in a slightly warm place, you'll feel very, very hot. You can feel nervous, and you'll get goiter, which is the enlargement of your thyroid gland, which can be felt in your neck. You can also get diarrhea. In extreme cases of unmanaged hypothyroidism, this can lead to what's called a thyroid storm, where basically your tachycardia turns into arrhythmias, your hypertension turns into congestive heart failure and can lead to shock, and your intolerance to heat can turn into a high fever. Now, zooming in on Graves' disease. Graves' disease is a certain type of autoimmune hypothyroidism, and I've gone into it here. So in this particular disease, we see the production of these anti-thyroid stimulating hormone receptor antibodies. I'm going to add in a little R there. And this leads to the overstimulation of the thyroid, leading to a hyperactive thyroid and hypothyroidism. So Graves' disease has all of these symptoms, but in addition, it has three kind of unique symptoms. Namely, exophthalmos, which is the proptosis or bulging of the eyes due to the deposition of glycosaminoglycans glycans and weakened eye muscles, which make your eyes stick out of your head a little bit. You also get diffuse goiter, which is due to the increased size of the entire thyroid gland. This can be seen in this image of a radioactive iodine uptake, which shows a diffuse uptake of iodine, as opposed to, for example, multinodular goiter, where you can see there are lots of areas of increased or decreased iodine uptake. And so the final thing that you get that's unique to Graves is something called pretibial myxedema, or dermopathy, which is redness and swelling in the shins, basically. And to test for Graves' disease, you can look for your thyroid receptor antibody. You can perform a thyroid scintigraphy, and this is what I demonstrated here, where you have the radioactive iodine, and you would see a diffuse increase in uptake in in Graves' disease. You could also take a biopsy, and you would see something like this here. So a normal thyroid looks like this. As opposed to here, we have a Graves' thyroid. And what you're going to see is these really crowded follicular cells. You're seeing scalloped colloid as opposed to the colloid that's being produced in a normal gland, which is a lot more kind of, what do you call it? I would just say that's more uniform and regular. And you're also going to see lymphocytic infiltration, which is can be kind of seen in the presence of multiple nuclei in the interstitium. Okay, so that is Graves' disease in the context of hypothyroidism. I'm also going to mention here that there's, you know what? ignore me. We're going to move on to what hypothyroidism manifests as. So, in case you guessed it, hypothyroidism results in decreased levels of T4 and T3. And this can be due to a problem with the thyroid itself, or it can be due to the reduced production of TSH from the anterior pituitary. So, causes include iodine deficiency, because if you don't get iodine, you can't form T3 and T4. Hashimoto's thyroiditis, which is an autoimmune destruction of the thyroid due to anti-thyroid peroxidase antibodies. So antibodies against this protein here, again, reducing your ability to produce T3 and T4. You can also get it in DiGeorge syndrome, which is due to a congenital underdeveloped thymus and parathyroid, which leads to a congenital hypothyroidism. And you can also get it post-surgically. So if you had hyperthyroidism and you get surgery to remove the nodule, you can get hypothyroidism post-surgery. And so the clinical features of hypothyroidism are those that would be kind of reflected in a person with decreased metabolism. And this can be remembered by the acronym Mum is so tired. This stands for memory loss, obesity due to decreased metabolic rate, malar flush and menorrhagia, impaired fertility, dry skin as opposed to sweating in hypothyroidism, mental and physical slowness, including prolongation of deep tendon reflexes, a gradual onset. You would feel tired and intolerant to cold, so you would feel very cold in even just room temperature rooms. You get a raised blood pressure, a decreased heart rate, low energy, and there are also cognitive and psychological effects such as depression. And similar to a thyroid storm, which is an exacerbation of hypothyroidism, the exacerbation of hypothyroidism is called myxedema coma, where you get your, you could fall into a coma, your intolerance to cold could lead to hypothermia, and you can get bradycardia, which is obviously all very bad things. Now, in terms of treatment for hyper and hypothyroidism, there are basically, for hyperthyroidism, you want to prevent the overproduction of T3 and T4. There's a few ways we can do this. One way is using iodine 131 or radioactive iodine. And what this does, it basically involves the use of radioactive iodine that gets uptaken by the thyroid and emits gamma and beta particles, leading to tissue destruction. So it's like very specific to the thyroid. However, adverse drug reactions can lead to radiation thyroiditis, a thyroid storm, so overstimulation of your thyroid gland because you are giving them iodine. If you overdo it, you can get hypothyroidism because you've killed off too much of the gland. And it can also worsen Graves' ophthalmopathy. So if someone has exophthalmos, it might not be the best idea to get them radioactive iodine as their first line of treatment. Another pharmacological treatment is the use of thiouracils, and this is for hyperthyroidism. And what these do is that they inhibit thyroid peroxidase. Our examples here are carbimazole, which is converted to methimazole and inhibits TPO. We can also use propylthiouracil, which, as well as inhibiting TPO, also inhibits the conversion of T4 to T3 in the periphery. So, again, those are things that kind of directly inhibit the thyroid. And thiouracils have a bunch of ADRs, including rash, nausea and vomiting, fever, arthralgia, neutropenia, and they can also cause hepatotoxicity and agranulocytosis. So for a person who's got tachycardia, they're sweating a lot, they've got all these hyperthyroidism symptoms, we can also treat their symptoms using beta blockers, such as propranolol, to control their adrenergic symptoms, such as palpitations, sweating, and tremors. And we can also give them immunosuppressants in the form of glucocorticoids, such as prednisolone, which is a corticosteroid. And this can mitigate severe exophthalmia, and they can also acutely inhibit T4 conversion to T3. And finally, the most drastic measure would be surgery to remove the part of the thyroid gland that's over-secreting. However, this can lead to a bunch of complications, including post-operation hemorrhage, recurrent or external laryngeal nerve damage due to the presence of those anatomical structures in the area, and hypocalcemia, which is usually transient after the operation, but can be due to the removal of the parathyroid glands, which are little pea-shaped glands that produce parathyroid hormone and regulate your calcium levels. And then the treatment for hypothyroidism is quite straightforward. It involves the administration of exogenous thyroid hormones. So you can give them thyroxine, which is the natural version of T4, or you can give them levothyroxine or liothyronine, which is synthetic T3 and T4. And the adverse drug reactions of this is obviously if you give too much, you can give them hypothyroidism, and also it can lead to osteoporosis due to the increased breakdown and remodeling of bone. Yes. One last thing to mention here is tests that can be used to differentiate between primary and secondary hypothyroidism. So, our pituitary thyroid axis includes the production of TSH, which stimulates the thyroid gland, and then the secondary thing that happens is that TSH stimulates the thyroid gland to produce T3 and T4. So if we have primary hypothyroidism, which is where we have a reduction in the thyroid gland's ability to produce T3 and T4, we are going to see decreased levels of T3 and T4 in the context of increased TSH, because we have TSH constantly stimulating the thyroid gland, but the thyroid gland itself is unable to produce T3 and T4. However, in secondary hypothyroidism, this is caused by a reduction in the pituitary gland's ability to secrete TSH. So we're going to see a decreased TSH despite an increase in T3 and T4. So the thyroid gland is still able to produce these hormones, but it's a problem with the pituitary gland not being able to produce thyroid-stimulating hormone. It's also good to note that you can have subclinical secondary hypothyroidism due to a normal T3 and T4, but an abnormal TSH. So you get your metabolism's all normal, or at least compensated for the moment, but there's something wrong with your pituitary secreting thyroid-stimulating hormone. All right, so that is the thyroid gland. That's a lot. But now I'm going to move on to the adrenal gland. So here I'm specifically talking about the adrenal cortex, which is stimulated directly by the pituitary. However, the adrenal gland also can be divided into the cortex and medulla, and I'll talk about the medulla in a little bit. So the pituitary releases adrenocorticotropic hormone, or ACTH. And this acts on 3 different parts of the adrenal gland. The zona fasciculata, which produces glucocorticoids. The zona reticulata, which produces androgens such as DHEA and androstenedione. And the zona glomerulata, which produces mineralocorticoids such as aldosterone. Starting with cortisol, or glucocorticoids, I'm mainly going to be talking about an excess in cortisol. So This is called Cushing syndrome. And this leads to an increase in VGL, blood glucose level. It leads to protein and bone breakdown and fat redistribution. And there are kind of two categories of causes of Cushing syndrome. The first cause is ACTH independent or exogenous. So you can get Cushing syndrome from prolonged glucocorticoid use, because you can imagine if you're simply ingesting glucocorticoids, it's kind of similar to ingesting too much thyroxine. You will get hypothyroidism. And here you would get hypercortisol or Cushing syndrome. The other category is ACTH dependent or endogenous. And this is due to Cushing disease, which refers to pituitary adenomas producing ACTH. And this, that's just a subcategory. So Cushing disease specifically means the pituitary adenoma producing ACTH. You can also get Cushing syndrome from an adrenal tumor that's producing too much cortisol. Now, the clinical features of Cushing syndrome can be summarized using the acronym BAM Cushingoid. So this is the buffalo hump, which is the redistribution of fat onto the back of the neck. Amenorrhea, moon phases, again due to fat redistribution. A person might appear crazed, they might develop ulcers, they'll develop these purple striae on their abdomen, and they'll also have hypertension, predisposed to infection, necrosis of the femoral head, glaucoma, osteoporosis, immunosuppression, and diabetes, and they'll also exhibit truncal obesity as well. So the tests that we can use to diagnose Cushing syndrome are these. So firstly, you can measure the free cortisol in someone's urine over 24 hours. You can measure their ACTH levels to determine whether or not it's Cushing's disease or the pituitary adenoma. You can use the dexamethasone suppression test, which I'll explain in a moment. And you can also use a CRH, corticotropin-releasing hormone stimulation, to see how this affects the production of cortisol. So the dexamethasone suppression test, quite simply, tests to see whether or not this is a pituitary or adrenal issue. Basically, what dexamethasone does is it suppresses the pituitary's release of ACTH. And so if you give them dexamethasone, and it's this is going to suppress ACTH, and if it reduces your cortisol, that means it's a pituitary issue. However, if you have a adrenal gland tumor that's just independently producing cortisol, giving them dexamethasone and reducing the pituitary producing ACTH is not going to affect the adrenal tumor that's producing cortisol. And so despite giving them dexamethasone, you're not going to get a suppression of, that's supposed to be a suppression of cortisol. Apologies, I'll correct that. Now moving on to the other parts of the adrenal cortex. Another thing that you might want to know is hyper and hypoaldosteronism. And so this is caused by, the production of aldosterone from the zona glomerulosa of the adrenal cortex. Quite simply, hyperaldosteronism, also known as Conn syndrome, involves the overproduction of aldosterone, which we know helps you to kind of reabsorb water and reabsorb sodium into your blood to increase your blood pressure. So in hyperaldosteronism, not only will you get increased ADH, you'll also get hypernatremia and hypokalemia. And because of this random mechanism, which I found out about, where basically a lot of cells have a potassium proton exchanger on their surface. And so if you get reduced potassium, as in the case of hyperaldosteronism, in order to increase your potassium, we're going to pump in your protons, leading to reduced protons and alkalosis. So basically, hyperaldosteronism can lead to a metabolic alkalosis. Of course, the same is true in reverse. So hypoaldosteronism leads to reduced ADH, which can lead to hypertension, and hyponatremia, as well as hyperkalemia. And again, if you get too much K plus potassium, this is going to be exchanged for protons and can lead to a metabolic acidosis. We're nearly at the end. Okay, so these are all cases of increased stimulation of the adrenal cortex. However, in the case of decreased cortisol, sorry, I probably should have put this before talking about aldosterone, but a case of decreased cortisol can lead to what's called Addison disease. So this is insufficient cortisol due to a primary hypoadrenal insufficiency. So the deficiency is in the adrenal gland itself. It's not due to the underproduction of ACTH from the pituitary, in Addison's disease at least. So the clinical features of Addison's include fatigue, weakness, nausea and vomiting, increased melanin due to ACTH overload, and this leads to hyperpigmentation. And also, this decreases your blood pressure, leading to venous pooling, and can lead to postural hypotension. So you'll feel dizzy when you stand up. And then just another note, in terms of the adrenal medulla, an important pathology to note is the pheochromocytoma, which is basically where you get the overproduction of adrenaline from your chromaffin cells, which produce adrenaline and noradrenaline and dopamine. And pheochromocytomas manifest as hypertension, headache, palpitations, and sweating. And although this isn't directly affected by the pituitary, it's just there for completion. Okay, so that brings me to the end of the summary. I just wanted to mention how all these things came together in our case. So our guy came in with a prolactinoma. And I've highlighted in red the things that he also experienced, in addition to sexual dysfunction. So our guy experienced hypothyroidism, and he exhibited prolonged deep tendon reflexes. He was tired, he was feeling cold in 22-degree rooms, and had bradycardia. He also was experiencing a form of low cortisol due to the suppression of ACTH, and this manifested as fatigue, pallor, and he felt dizzy when he was standing up, so postural hypotension. And yeah, I think that's it. I think that covers everything. Oh, yes, and specifically, our guy also had reduced body hair, reduced libido, sexual impotence, hypogonadism, small testes, and fine wrinkles on his face. So I thought that was a really, really cool little summary of like how everything came together. It was very satisfying to make this and then go through the case. So that's it. That's anterior pituitary hormones. I hope that all makes sense. Thank you for listening. That was a very long one, but this will probably be the last video I make, and hopefully I pass my exams. Okay. Thank you. Love Val. Okay.